Our next speaker is Associate Professor James Trauer from Australia. He's the Head of Epidemiological Modelling Unit at School of Public Health at Monash University. Over to you, James.
My name's James Trauer, and I'm a respiratory and public health physician, and I'm also Head of Epidemiological Modelling at the School of Public Health and Preventive Medicine at Monash University. And I'm going to be talking about real-time modelling of a pandemic and the challenges it has thrown up this year. Clearly, the pandemic's had a huge impact on everybody's lives and the economy and society, as well as health. And it's been a huge challenge for modelers as well. It's been something totally unprecedented from my point of view. I've previously been a modeler that's focused on tuberculosis being a respiratory infection, and it's a very different situation. The challenges of modelling a pandemic mean that the ground is always moving under you. The moment you try to simulate something, the epidemic has changed, and you're always chasing your tail, trying to understand what the data means. And by the time you've produced a simulation, it's often out of date, or the model needs to be recalibrated the following week. So I'm going to talk about some of the issues around COVID-19 and understanding its epidemiology and transmission, and how we've tried to put that into models and what that can tell us about the future pathway of the epidemic. So to start off, I would like to introduce probably the most widely used framework for infectious disease modelling. This is an SEIR model. There's a lot of different things that can be referred to as a model, but when people talk about mathematical modelling, we're usually talking about some sort of mechanistic framework. And I like the word mechanistic because it conveys the fact that we're trying to explicitly represent the mechanism of disease transmission that underlies what's happening in the population. And so the SEIR framework represents the population as being in these compartments. So each compartment is associated with a number, which is the number of people in that state in relation to COVID-19. And so the S compartment is the number of people susceptible. The E compartment is the number of people who have been exposed but haven't yet developed symptoms. The I compartment is the number of people who are now symptomatic and also infectious. And then as they transition into the R compartment, they recover or become removed from the system. And in this framework, they can't then be infected again. And so it's a pretty simple system. It's only comprised of 4 compartments. And if you think about the R0 of the epidemic, that's the number of people who are infected by one infective person on average in a fully susceptible population. And this model does a pretty good job of capturing some of the dynamics of that early phase of epidemic growth. So in the illustration on the left here, you can see that we have one person infecting 2 people in the next generation of infections, and then that progresses to 4, 8, 16. And the model, if you just set it up as described in that SEIR framework, you get that exponential growth, and the model does a pretty good job of capturing that. You also get the general bell-shaped curve of the epidemic, and we've all seen a lot of curves over recent years, over recent months. We've probably got a little bit bored of looking at curves and being told to flatten the curve. And the curve itself, if we think about an unmitigated epidemic, an epidemic in which nothing is done to control the virus, does look indeed a bit like a bell shape. That's what we would predict from the models. That's what the SEIR framework can show us. And in reality, if we had done nothing to control the epidemic, we probably would have got this very large bell shape. So the model tells us a little bit about that. It tells us that the peak of the bell is the point at which herd immunity is reached, and the downslope after that peak is actually extra infections that are not required to reach herd immunity. So we know that if we were to let the epidemic play out totally unmitigated, we would actually have far more infections than we would need to prevent a second wave, and so people would unnecessarily be infected and die. And it also tells us that as we get towards the tail, that tail off occurs because the number of susceptibles in the population gradually decreases. It doesn't drop down to 0, but it gradually decreases. So this is the sort of framework that was used prior to the pandemic by organisations like the CDC to propose a response, but it was very much informed by the expected response that we would need to have to an influenza pandemic, given that so many new pandemics are caused by influenza viruses. And so the plan really for an influenza pandemic and responding to it was to mitigate the epidemic, just to flatten the curve. So this is certainly what flattening the curve meant to me in March. It seems to mean something totally different now, but in sort of the early months of the year, flattening the curve in Australia meant that we were anticipating a very large bell-shaped epidemic, and we were going to try to squash that down to a much, much flatter bell, but still a pretty substantial epidemic. We were never at that stage trying to totally eliminate or suppress the epidemic. The idea was that if we could flatten the curve to some extent, we could keep the number of cases below what would have overwhelmed our hospital capacity, but still allow substantial community transmission. And that is essentially what happened in the 2009 influenza pandemic. We didn't totally stamp it out. Probably somewhere around 15% or a little under of the population were infected by 2009 H1N1 influenza. And that may still happen, I suppose, in the case of COVID-19, but at this stage it seems like a lot of countries are really pushing towards well, countries like Australia and New Zealand are certainly pushing towards having very low levels of transmission and trying to keep things such that a very small proportion of the population are infected. So in these early months of the year, models were already informing policy and telling us, predicting what might happen. This was perhaps one of the most widely cited and well-recognised papers that was led by Neil Ferguson from Imperial College. It was an agent-based simulation, which is a bit of a different sort of a model. It sort of fits into the SEIR framework to some extent, but it explicitly represents every individual person within the population as an individual, and it explicitly says what they're doing, where they're going, who they're interacting with. And so this model received a lot of criticism after it was published because of the way in which it was coded. And if you look at the outputs from it, it actually gives us pretty similar outputs to what the SEIR framework does. It basically just gives us a bell-shaped curve. So there's a range of epidemiological models that are all mechanistic. I guess that's the thing that they share in common. But they're all quite different in terms of the engine underneath the bonnet that is driving how the epidemic plays out. But even these very sophisticated or complicated epidemiological models that are based on agents and individuals interacting still give us this sort of general bell-shaped curve which still captures those fundamental aspects of an unmitigated epidemic. And so this model was very influential, and its main conclusions, I think, were still very sound in spite of the criticism that it received, in that it did alert people to the huge burden of infection that we might expect if we did nothing to mitigate the COVID-19 epidemic. So these bell-shaped curves tell part of the story, but the thing that they don't really tell, as well as this figure that also appeared in the same paper, is just how enormous the epidemic would have been had we done nothing from the outset. Because that horizontal red line towards the bottom of this graph is the surge critical care bed capacity. So that's additional resources put in place in the UK or the US to allow for additional people to be admitted to ICU on top of what is normally available. And you can see just how enormously the curves smash through that threshold in the case of an unmitigated epidemic. But even in the case of a mitigated epidemic, which is something like the orange curve, where we have restrictions in place for a certain period of time in that grey area, but then we release those restrictions and try to just get by with case isolation and some milder social distancing interventions, that is still it's a flatter curve, and flattening the curve, I suppose helps to some extent, but it still is way, way, way over what our surge critical care bed capacity would be expected to be. So that was, I think, very informative, very useful, and was very influential, and that was useful information to have early in the epidemic, and it sort of was incorporated with the fact that we were observing very high rates of disease and ICU occupancy in countries like Italy, and we did see a major catastrophe there in the early months of the year. So it became clear that those general messages from the model were correct, and that the COVID-19 epidemic was going to have a massive effect. We put together a short paper that's available in medRxiv that does a similar sort of thing to what was proposed in that agent-based simulation by the Ferguson group at Imperial College, but does just use an SEIR framework. And so it was essentially just a compartmental model and a deterministic model, not simulating individuals as Ferguson's group did. So essentially it's SEIR. Really, we've split a couple of compartments into two for reasons I won't go into, but really the only thing that we wanted to add on to this was just an additional compartment just to simulate people in intensive care units, to explicitly be able to estimate the number of people who would be admitted to ICU over time if we had a major epidemic in Australia. In the top panel here, we have the totally unmitigated epidemic to the left. So this is if R0 or the R effective or reproduction number remains well above 2, we would see this huge epidemic that overwhelms critical care capacity, with that horizontal dotted blue line being the critical care capacity. If we did some sort of moderate measures, you can see again that we flatten the curve to some extent. That's the second curve in the top panel. But the number of people in ICU still massively overwhelms even our surge critical care capacity. If we try to knock the reproduction number down even further to perhaps 1.2, we can keep numbers down to within critical care bed capacity, but you can see that the epidemic plays out then for a much longer period of time, and it's perhaps mid-2022 before the epidemic is over, by which time we might hope to have a vaccine. So that shows, the idea of this is to illustrate that the idea of partially mitigating a major outbreak in the case of COVID-19 was much more problematic than what might have been anticipated for an influenza pandemic, just because the number of people requiring ICU and the severity of the disease was much greater in the case of COVID-19. In the lower panel there, we have what happens if you just go that little bit further and rather than reduce the reproduction number to 1.2, that you try to just knock it down somewhere below 1. And so if you try to keep it at 0.8, for example, you basically don't have an epidemic. The blue line is then right at the top of the graph, and the number of people getting infected is right down at the bottom. And so you have very limited transmission, and you don't have to worry about critical care capacity at all. So the message here was that if you're going to put in place a lot of very major interventions to try to knock the epidemic down from a reproduction number of 2.4 to 1.2, you might as well put a couple of extra ones in place and try to get down to 0.8. And a lot of countries are trying to do that, such as Australia and New Zealand, although some countries just don't have the resources or the opportunity to be able to do that. The flip side of it, though, is that we don't get close to reaching herd immunity if we take this pathway. So if we think about the unmitigated epidemic, that's the solid black line, and the green horizontal bar is the herd immunity threshold. And the vertical axis is the proportion or the number of people in Australia who are still susceptible to the epidemic after the first wave. So if we were to have let a huge unmitigated epidemic occur, as I mentioned, we would go past the herd immunity threshold and more people would be infected than is necessary. If we get down to that point of just carefully trying to find our way to the herd immunity threshold with an R effective reproduction number of 1.2, we would have a very large epidemic, as we saw. We'd still overwhelm critical care capacity, and that's the dashed line. If we try to keep things under enough control to stay within critical care capacity, that's the dotted line, and we're still nowhere near the herd immunity threshold. Whereas if we go for this intermittent strategy of trying to keep the epidemic suppressed and keep the reproduction number to very low numbers and below 1, well, not very low numbers, but just somewhere below 1, we basically end up with the entire population remaining fully susceptible to the epidemic. So that means that we still have the potential for explosive outbreaks if we release the brakes on the system and the reproduction number pops back up above 1. So unfortunately, this illustrates that no strategy is perfect, and any pathway that we choose has a lot of problems until we have a vaccine that can provide us with a technologically based solution, but I think it's really important to understand things in this context, and that the herd immunity threshold, as much as it's become a bit of a dirty term, is a really important concept for understanding what's going on in the background of the epidemic. So why is COVID-19 so hard to control, and why is it like this, and why haven't we been able to do what we did with SARS, for example, in 2003 and control it? And why is it also so different from influenza? Well, I've already discussed the fact that it's more severe than influenza. And in the case of influenza, there were a series of epidemics, of course. We tend to get them every 10 to 20 years. The last really major one was in 1918. So this graph is from that same document from the CDC that plots each of the epidemics according to their severity and their transmissibility, their infectiousness. So that if you're in the top right in that black area, you're a particularly nasty pandemic, and if you're in the bottom left, you're perhaps a bit of a milder or more controllable epidemic. And you can see that gradually, over time, through the course of the 20th century and beyond, the pandemic seemed to get a little bit milder on the whole. So the 1918 one was a disaster, but nobody remembers that now because it's too long ago for anybody to be able to tell us about, so we just have to read about it. And then as the 20th century evolved and played out, the epidemic seemed to march from that top right down to the bottom left, not consistently, and this is a totally random thing, of course, but I think it just illustrates how the epidemics and the history of the pandemics perhaps lulled us into a bit of a false sense of security. The ones that we were able to remember better were the milder, more controllable ones. And so we weren't as prepared as we might be for a very major and very transmissible and very severe pandemic. So to understand a little bit about why COVID-19 might be particularly difficult to control, I just want to talk about a patient's journey through the course of infection, disease, and recovery. And this is a brief timeline. You can think that at the start of the blue box there that somebody's been infected. Sometime after that, they become infectious, then they might develop symptoms. They're then detected by the medical system, and some time after that, they would hopefully be isolated, and perhaps even later than that, they might be notified to the public health system, and their data might work through the surveillance system so that they appear in the numbers that we see every day. There's some quantities that we talk about in epidemiological modelling called the serial interval and the generation time. So if you think about the person who, the index case is that top line, and then the person who they infect is the bottom line. The generation time is the interval between one person being infected and the person they infected getting infected. And the serial interval is the time between that first person developing symptoms and the person they infected. So these principles were what underlied a paper that was published in Nature Medicine that looked at data from a hospital in southern China, 2 different data sets. This is one of the data sets in which you can see the exposure window between 2 people, one who was the index case who did the infecting and one who was the secondary case who was infected by that person. If you look at the delay between the red dot and the blue dot, you can get a sense for when the primary case had their symptom onset and the secondary case got their symptom onset, and how that relates to the window of exposure. And so that allowed these, so they had information basically on the serial interval, the interval between one person getting symptoms and their infected contact getting symptoms, and they could say when those people had come into contact. So that gave them enough information to be able to reconstruct some information about the infectiousness profiles of the individual with COVID. The other piece of information, or the other data set that they had available, was what's called a cycle time, which is the higher the number, the more virus somebody is producing, I suppose, is the easiest way to think about it. And people had this information available from the point of symptom onset onward. And so we could see that as cycle time went up in number and that line goes down, as time goes along, that quantity sort of reduces. So what we're saying is that people are getting less infectious over time from developing symptoms. And the thing that they really wanted to emphasize here was that right from the very start, from day 0, that line already appears to be sloping downwards. And the data's a bit noisy, but what they're saying is that even at the point at which we start observing people with symptoms, their infectiousness already seems to be decreasing. And so what that suggests is that the peak came before their symptoms started. And so combined with that data on the serial interval, we can reconstruct some sort of picture of how infectiousness plays out relative to the point at which symptoms start. And these were some other figures from this paper. And in the top right, we have sort of a, I guess this doesn't come from data, but it's an illustration of what we think was going on with SARS in 2003, that the primary case has a period of time in which they're asymptomatic, that's the blue boxes on the left, and then they develop symptoms as they enter the purple boxes towards the right. And in the case of SARS, we generally thought that most of the infectiousness, which are the blue bell-shaped curves, most of the infectiousness occurred after symptoms commenced. So it meant that public health interventions had the potential to be a lot more effective by identifying people after they had symptoms and isolating them promptly. You could cut out most of their transmission. That's to some extent similar to seasonal influenza in the bottom right, although there's probably some transmission that occurs prior to symptoms starting. But these researchers were able to present data that suggests that in the case of COVID, we might have something that's a little bit more along the lines of the panels on the left. So, for example, in the top panel there, we have the bell-shaped blue curve having a substantial proportion of its mass to the left of symptom onset. So a lot of people are getting infectious before they have symptoms, which makes it very difficult to identify these people in time to isolate them and stop them from infection. So the third thing I'd like to talk about, and probably the last thing, is thinking about data and trying to quantify the COVID epidemic, which you would think would be very easy given how many people have had COVID and how the internet is making data very accessible to a large number of people, and a lot of people are watching websites like the Johns Hopkins website or COVID-19 data in Australia. But if we look at cases or notifications, actually they don't really tell the whole story. They tell a lot of the story in some countries, like towards the bottom of the graph here, we have that in Australia we've had very high testing capacity. And this is the estimated proportion of symptomatic cases that we think are detected. In Australia, we think most symptomatic cases have been detected since pretty early in the epidemic. And that's been very variable, but a lot of countries have done well, such as Malaysia and Australia. But in contrast, in the top part of the panel, there were a lot of countries that, particularly for ambulatory patients who were not admitted to hospital, there just was very, very little testing capacity. And in a sense, for some of these countries, testing was not really a major component of their response. So, for example, in the UK and France, the proportion of people who were not admitted to hospital who received the test and were effectively diagnosed was very, very small. Which has implications for whether those people can then be isolated, of course. And so it has implications from the perspective of the public health response, but it also has implications in terms of understanding the epidemic in these countries. So, for example, in France, we really have to use modelling to give us a sense for how big the epidemic is. And those models, this is an example of a model that was produced by Simon Cauchemet's group and published in Science, which was a very major and influential piece that aimed to give a sense of the epidemic in France. And it did as good a job as it could. It was fitted to the data that were available that included things like hospital admissions and general ward beds being used, and made some use of notification data. But there were a fair few assumptions that needed to be fed into this model, such as the infection fatality rate, which I'll talk about a little bit later. And so I guess what the model in a sense is doing here is that it's compensating for the fact that we don't really have a good sense from surveillance data about what the size of the epidemic was in France. So the model was needed to reconstruct that. And there's things like the proportion of people infected using surveillance data, because such a small proportion of people were actually identified, is not a satisfactory way to work that out. And so the model can give us a sense for that. Serosurveys are an even better way probably of working that out. But for example, in panel E, you can see that they estimated that even after this major epidemic, only around 4% or 6 to 7 at most of the population had been infected. So some of the most important quantities to think about are the infection fatality rate. The case fatality rate is something that's discussed a lot, and it's important to understand the difference between these two things. So the case fatality rate is the number of deaths divided by the number of cases that are identified. So if you look at the daily notifications for some of these countries, that's the denominator in the case of the case fatality rate. But as we've just discussed, it's extremely dependent upon the testing capacity, because in some countries they're just not, the denominator is really very unknown, or might be very small compared to the number of infections that have occurred. And so that inflates the case fatality rate. So what we're really more interested in as epidemiological modelers or epidemiologists is the infection fatality rate, which we think is a little bit more consistent between countries regardless of testing capacity. And that's defined as the proportion of infections that result in deaths. So the number of COVID-19 deaths divided by the number of infections. And that's a quantity that we're more interested in, but then it's also a little bit more difficult to identify because we don't necessarily know how many infections have occurred in the population. So even models like the one that I presented from Simon Koshme's group have limitations, and they have to make assumptions about things like the infection fatality rate. So the infection fatality rate in papers like this and other ones are estimated from small groups of patients who are very well described. So an example is the Diamond Princess, which is a cruise ship that people would probably have heard of, that docked in Japan and had a major outbreak. And just about everybody on the cruise ship was tested. And so we know the size of that outbreak pretty well. And it was an outbreak that had particular characteristics of its own, which I won't go into, but it's assumed that we can estimate the infection fatality rate because in this case, it was possible to identify all of the infections. So we think there were 712 infections on the Diamond Princess. And we have some sense for the number of deaths that occurred, although even for that, there are still some people who are in long-term ICU who, well, at the time of publication of the Koshme paper, they were, but even determining the number of deaths, there are some issues, but we can have a pretty good idea. So there were 14 deaths and 4 people admitted to long-term ICU, so somewhere between 14 and 18 deaths among 712 people. And though they were distributed very much towards the older age groups. And so papers like this, or studies like this, have been what has been used to estimate the infection fatality rate, which we know is, of course, very, very different according to age group. I think, so the reason that I've described this is because it just highlights how, in spite of the number of deaths and the number of cases that have occurred, to work out the infection fatality rate, we're still going back to relatively small groups of people who have been well described to calculate these critical quantities for our models. And perhaps the only other way to think about the impact of COVID-19 is to look at all-cause mortality, which is a really useful thing to do. And we can see that it's spiked up in just about all countries across the world since the start of the pandemic, to a very major extent. And so you can see the ones that are identified as having been COVID-19 deaths here illustrated in orange, and that sits on top of a sort of a grey background underneath that gives more of a sense of the all-cause mortality. And for the particular time of the year, the dashed line is what you would expect for each of these countries. And so you can see again how the infection, the number of deaths, the mortality, all-cause mortality rate has really risen up very markedly above that. And so in a lot of cases, that's to a greater extent than the orange area would suggest, so that even some deaths that are not attributable or haven't been attributed to COVID-19 are probably a consequence of it. That's something that's really important and good to do in countries that have good vital registration systems and good records of deaths, but actually that's not always the case, and a surprising number of countries around the world, and a lot of low and middle income not have high quality vital registration systems. And so getting a sense of what's going on in low and middle income countries is difficult. But even in countries that have some data, such as Jakarta, where there's monthly information on burials, we do still see a similar pattern. So it does seem that the extent of the pandemic in low and middle income countries is probably greater than was previously, probably greater than is recognised from surveillance statistics. So in this example in Jakarta, you can see that in March and April of this year, there were considerably more deaths overall, or considerably more burials occurring, even though a very small portion of that additional number was attributed to COVID-19. So we think that there was probably quite substantial transmission going on under the surface that wasn't recognised. So I will finish up there, but just quickly to recap, and I've left a few slides out at the end, but happy to discuss other issues in the discussion forum later. COVID-19 has presented huge new challenges for our models, even constructing models that capture the epidemic. By the time you've published them or even constructed them, a month or a few weeks later, you might be in the middle of a second wave and you have to really totally rethink about what your model needs to look like. Modelling has been undertaken at breathtaking speed. It has given some really important messages that have influenced policy in the early phases of the epidemic, and many of them, despite the criticism, were broadly correct. And even the simplest models can provide insights into the current situation and how we should be responding to it. And despite the number of cases reported, the data that we're using to inform our models remains imperfect. Thanks so much for your time.
Thank you, Associate Professor James Trauer, for a great presentation.